Okay, cool. So I kind of shoehorned this in a little bit, but I think it's really important for us, and the terminology is really important for us to understand as well. But before that, Wendy made a good point, and I just wanted to emphasize it. In elderly patients that present with behavioral changes, in addition to neurological issues, one of the first things that you should consider as well is, does that patient have a UTI? I actually worked in a nursing home. I was what they call a licensed practical nurse. Back when I was a nursing student, when you got halfway through nursing school, you could take what were called your practical nursing boards. And so I did, and then for the second half of nursing school, I worked as an LPN at a nursing home. And we actually had protocols where if our patients started acting differently, one of the things we did was we collected a urine on them and sent it for a UA, just as a matter of axiom, because UTIs are really common. So I just wanted to kind of bring that little point up. Okay, so now let's go ahead and just talk about something that's very general. You can have urosepsis, which is sepsis involving the urinary system, but sepsis is much more broad than that. And there's lots of terminology, and I want to make sure that you guys are okay with the terminology here. And so I'll spend a few minutes talking about that, and then I'll spend some time talking about just general treatment for sepsis as it applies to us as pre-hospital providers. And all the material I'll be referencing won't be in your book necessarily, but it will be from one of the definitive sources for sepsis. It's called the survivingsepsis.org. It's the Surviving Sepsis Campaign, and they have done a really good job of pulling together all of the evidence and making evidence-based recommendations for how we approach and manage patients that may be septic. So I will pull some of the guidelines up, not on my iPad. I actually have them pulled up through the computer, so I won't be able to record that, but we're still going to go through them real quickly anyway. Okay, so when we talk about sepsis terminology, what I want you guys to think about is I want you to think of sepsis as a continuum of severity, where as we go further down this continuum, we're getting more and more severe, more and more problematic. Our patients are more and more critical. So at the top of this continuum, we have something known as SIRS. Have you guys ever heard of that? SIRS? S-I-R-S? And it stands for Systemic Inflammatory Response Syndrome. So as you might imagine, it involves systemic or body-wide inflammation, a body-wide inflammatory response. Now, when I get a run-of-the-mill infection, where does that inflammation tend to be? The run-of-the-mill infection. It tends to be local, right? It tends to be local to where that infection is. Well, in a systemic inflammatory response syndrome, that inflammation is body-wide. Even though the infection may be localized, there is body-wide inflammation. You guys cool with that? Okay. So then from SIRS, we can move on to sepsis. Okay. And then from sepsis, we can get even more severe and move into something called severe sepsis. And then from there, we can move on to septic shock. And then finally, we can move on to the most severe manifestation of all this, known as MODS. MODS stands for Multiple Organ Dysfunction Syndrome. Some people still call this multi-organ failure. Okay, but MODS is the contemporary terminology that's currently being used. All right, you guys okay with that? Okay. So I think the next question to ask is, well, what do these really mean? Do we actually have a well-defined way of identifying these? And the answer, surprisingly, is yes, we actually do. So let's talk about the criteria for identifying these. So let's start at SIRS. Okay. So to say that somebody has SIRS, okay, there are 4 criterions that we look at, and we need to have at least 2 of the 4 present, 2 or more, okay? So the first one is hyperthermia or hypothermia. Wait a minute, I thought people that had infections got a fever. They can also present with hypothermia, specifically when they are critically ill. And there is some terminology that's still used where there are different phases of somebody going through septic shock. There's what's known as the hyperdynamic phase. And this is your classic patient who is tachycardic, they have a fever, their blood pressure may not be altered significantly, okay? And then there is what's known as the hypodynamic phase, where they start to crash and they're vasodilated out and they're cool and their temperature drops and their blood pressure drops and they look like they're near death. Okay, and this is something we can sometimes see with people. As they get sicker, they'll transition from the hyperdynamic phase to where they're compensating reasonably well into this hypodynamic phase where they're dying. But this is the terminology that we commonly use, the SIRS, sepsis, severe sepsis, septic shock, and MODS. Okay, so their temperature should be either greater than 38 degrees Celsius or 100.4 Fahrenheit, or less than 36 Celsius or 96.8, excuse me, okay? That's one of the criteria. An elevated heart rate is the next one, generally greater than 90 per minute, okay? So they have a tachycardia. They're going to have an elevated respiratory rate, either greater than 20 breaths a minute, or if we can measure their CO2, their PaCO2 should be less than 32 millimeters of mercury. So they're hyperventilating. And then finally, changes in your white blood cell count, specifically leukocytosis. And what is leukocytosis? What does that mean? What does cytosis in general mean? Yes. You have increased cell division, which is going to do what? There we go. Increased. So anytime there is a cytosis, that means you have an increased number of cells. So leuko means white, right? So leukocytosis is increased white blood cells, right? Does that make sense? Now, penia, on the other hand, penia means a low cell count, so leukopenia would be a low white cell count, okay? Does that make sense? Okay. So, you could either have a significant leukocytosis or a significant leukopenia. So, if your white count is greater than 12, okay, or the proper way of looking at it is 12,000 cells per, okay, right? Because we're looking at number of cells per volume. Or less than 4,000 cells per. You guys okay with that? Okay. Or there's one other criterion. Greater than 10% bands. Does anyone know what bands are? I know we haven't talked about hematology yet, so that's okay, but what are bands? Huh?
Hematologist?
No.
Sort of. So when you look at somebody's white blood count, and their white blood count is 15,000 cells per cubic milliliter, is it? I believe. Probably. Right. 15,000, right? Is that leukocytosis? Yes, right? It's greater than 12. Yeah. For sure. Significant leukocytosis. Okay. Does that tell you anything about specific white blood cells? No. How many different types of general types of white blood cells do we have? 5, right? Never let monkeys eat bananas. Just remember that. Never let monkeys eat bananas. So you've got neutrophils, lymphocytes, monocytes, eosinophils or eosinophils, and basophils. Never let monkeys eat bananas, right? Neutrophils, lymphocytes, monocytes, eosinophils, and basophils. Those are your 5 general types of white blood cells. When we look at the bands, that is looking at the neutrophils. Okay? We have 2 general types of neutrophils. You have your segmented neutrophils, or what we call your segs, and your banded neutrophils, or what we call your bands. Okay? Segmented neutrophils means that the nucleus is segmented out, and these are mature. These are mature neutrophils. They've had time to mature. Banded neutrophils, on the other hand, are immature. So these are neutrophils that have been sent out into the front lines before they've had enough time to mature. Does that make sense? And so if you had to guess, if you had an overwhelming infection, are you going to have higher levels of mature or immature neutrophils? Immature, right? Because what's the body doing? Yep, women and children to the front lines, right? Get up there and fight. I don't care. I know you haven't had enough time to train, but you need to get up there and do your thing. And so that is what we mean by greater than 10% bands, is the body is sending the immature neutrophils to the front line to fight this infection that's overwhelming. Does that kind of make sense there? You guys, and I know we haven't talked about hematology yet, and we will actually have a hematology lecture, but might as well touch on it a little bit here, right? Cool. You guys good with that? So you have to have at least 2 out of these 4 criteria. So if your patient has at least 2 or more of these, they meet the definition for SIRS, being in SIRS. Okay? So now, we also have this concept known as sepsis. Okay? And sepsis is SIRS plus an infection source. All right? So your patient has these signs and symptoms, or these signs rather, and they have a probable infection source. Okay? You've identified, oh boy, that looks like there could be an infection there. You put those 2 together and you can say your patient is now in sepsis. If they just have SIRS criteria by themselves and you can't identify any infection source, then they are just in SIRS. Does that kind of make sense there? Okay. Now there is another term known as septicemia. What does septicemia mean? Does it mean infection in the blood? It just means the presence of bacteria in the blood that was drawn. Septicemia does not mean that you are in septic shock. Does not mean you have SIRS. It does not mean you are septic or in sepsis. Does that make sense? Again, that's why I wanted to go over this terminology, because it is kind of confusing. Septicemia is simply the presence of blood, or of bacteria, an organism in the blood. Now, septicemia may be associated with SIRS, sepsis, severe sepsis, septic shock, and MODS, but not necessarily. Okay? Is that okay there? I just want to make sure we're okay on all this terminology. Okay. So, if you have SIRS criteria met, and you have an infection source, we say that you are in sepsis. Does that make sense? Now, there is also the concept of severe sepsis. And severe sepsis is sepsis. So in every case, you see kind of how these build upon each other? Right? You cannot be in sepsis without SIRS, right? You cannot be in severe sepsis without sepsis, okay? And of course, sepsis includes SIRS, right? So you have all of these blocks in place, right? Does that kind of make sense? That, okay, I'm in SIRS, okay, now I move on. Do I have an infection source? Yes, I do. Now we move on. If you have sepsis and you have organ dysfunction, hypotension, or hypoperfusion, okay? Organ dysfunction, hypotension, or hypoperfusion, we say that you are in severe sepsis. What are the major things that we look at for severe sepsis? Okay? We look at lactate levels. If your lactate level is elevated, what does that indicate? It indicates hypoperfusion to the cells, right? Does that make sense? Because if your cells are not being perfused, they are transitioning into anaerobic glycolysis, or that's all they have available to make ATP, right? Right? And remember, that pyruvic acid coming out of glycolysis cannot go into the Krebs cycle, right? And then that pyruvic acid is converted to lactic acid, and then lactic acid dissociates, right, into its conjugate base, lactate, and a hydrogen ion, right? It does what acids do, and it is the lactate that we can measure, right? So if your lactate is elevated, or you have lactic acidosis, that indicates that you have cellular hypoperfusion, okay? If the systolic blood pressure is less than 90 millimeters of mercury, or your patient experiences a decrease in their systolic blood pressure greater than or equal to 40 millimeters of mercury. Either of those two indicate hypotension. Does that make sense? You guys okay with that?
How are we going to differentiate the field between severe sepsis and septic shock?
Well, we haven't even talked about septic shock yet.
The hypotension, the increase in the blood pressure, respiratory rate, that's going to scream shock. So how are we going to, well, I want you to continue.
Are you okay so far?
Yes.
Okay, I haven't given you all the information yet, but are you okay so far? Right? Let's not go to septic shock quite yet, but are you guys okay with what sepsis is, or what SIRS is?
Yes.
What sepsis is, and what severe sepsis is? You guys okay with that? Okay. So now the jump from severe sepsis to septic shock is a subtle little nuanced issue. Okay? And this is what enables us to say that somebody is in septic shock. They have to have severe sepsis. You guys good with that? Does that make sense?
Yeah.
But the difference is your patient has hypotension that does not respond to fluid resuscitation. That is the key differentiation. So you probably have run into a lot of patients where the paramedic said, this patient's in septic shock. And the patient may not have been in septic shock. Again, what needs to happen for a patient to be in septic shock?
All of that.
Severe sepsis that does not respond to fluid resuscitation. So we cannot say somebody is in septic shock until we have adequately fluid resuscitated them. Does that make sense? So once you have done adequate fluid resuscitation and the patient does not respond, then we can say what? Septic shock. Does that make sense? So you start at SIRS, sepsis, severe sepsis, septic shock. Does that kind of make sense? And then finally, you can have what is known as MODS. Remember that, multiple organ dysfunction syndrome. And with MODS, you have to have evidence of greater than or of equal to, greater than or equal to 2 or more organs failing. So you have to have evidence that 2 or more organs or organ systems are failing, okay? What kinds of things would tell you that your organs are failing? Labs, right? So you do an ABG and your PaO2 is really low. That tells you that your lungs may not be working very well, right? You do renal tests and your BUN and creatinine is really elevated. That may tell you your kidneys are dysfunctioning. You do LFTs, your liver function tests are elevated, your bilirubin's elevated. You have a coagulopathy, you have a blood clotting disorder. That tells you that your liver or your hematopoietic system, your blood system is failing. Does that make sense? Your pancreatic enzymes are really elevated. Maybe your pancreas is failing, okay? You have severe alteration in mental status. Maybe your neurological system is dysfunctioning, okay? So anytime you have evidence that greater than two or more organs or organ systems are failing, you also have MODS in addition to that. Does that kind of make sense there? You guys okay with that? What the terminology, the difference in terminology is? All right, very cool. All right. So I want to go back to this whole infection sources thing. So if somebody looks like they may have an infection, just think of your W's. Think of your W's. These are the most common problems or infection sources, okay? Wind. What do you think wind refers to? What do you think wind refers to? We're talking infection sources. Wind. There you go, lungs. Right? Specifically pneumonia. Right? Pneumonias. Water, what do you think that refers to? We just got done talking about it. Yeah, so your nephrology and your GU tract, specifically urinary tract infections, right? Wound, what do you suppose that means? Yeah, any open or post-surgical area. What do we mean by wonder drugs?
The antibiotics.
Good, so do we have antibiotic, right? And that may increase our possibility of a resistant infection, or could it be just a drug reaction that is manifesting like an infection, right? I have an adverse reaction to a drug and I get tachycardic and I get a fever. I don't necessarily have an infection, but I'm having a drug reaction. It's always something you want to think about. And then walking. Because what do we like to do right after somebody has a surgery? What do we like to do as soon as we can? Get them up, walk them around, and that prevents what? Pulmonary emboli. Remember, a pulmonary embolism can present as an infection, right? They can have dyspnea, they can have tachycardia, they can even develop a fever due to the inflammatory cascade that happens with the pulmonary embolism and not necessarily have an infection. So you guys good with that, the 5 W's? Physicians often say that these are the 5 common causes of fever in a hospitalized or post-surgical patient. You guys good with that? All right, cool. So I'm going to stop here and I'm going to go to the surviving sepsis. and I'm going to pull up a few relevant things for us there.